Good afternoon. Today we'll be talking about molecular diagnostics and cytopathology. My name is Dr. Hoda Amer. This presentation was originally presented in July 2019 at Wayne State, and American Board Certified Doctors for Egypt are not responsible for the contents of this lecture. So let's go ahead and get started talking about molecular diagnostics in cytopathology. To begin with, we have to understand the concept of triage and the methods. So there are two main molecular methods for screening. There's either targeted, like prior sequencing and PCR. There's also next generation sequencing, and there's the Sanger screening, Sanger sequencing. Sanger sequencing can screen for all of the mutations. So it needs a large percentage of tumor cells, at least 30 to 40%, while the targeted kinds need much less, like about 5 to 10%. And they have a shorter turnaround time. You can also look at it by DNA. So next generation sequencing needs about 10 nanograms of DNA. Obviously, you can look up and see how these work and so on. The idea is that they, depending on which one is in your institution, that's how much tumor cells you're going to want to provide for the testing. Now, for fish also can be done, which is, and there's, you can use the whole slide. It can be done on direct smears and so on. And these have a low cellularity of 50 to 100 cells. So there's different strengths and weaknesses of each, right? So you can't do immunohistochemistry on a smear, very limited otherwise. But fish, you can do it. PCR and NGS is fine for low tumor volume. And you can also adequately guarantee it by rows. So the rapid on-site, that's where the pathologist comes in. There's quite a few advantages of actually using cytology for molecular testing, including that it's a rapid fixation. There's no formalin that will affect the nucleic acids, minimally invasive instead of taking out a huge biopsy. The limitations is that depending on each institution and the different kind of fixative used, each one would need a kind of validation. You have to focus on concentrated areas, and lastly, the slide has to be sacrificed. So, so triage, what exactly is triage? When you come to rows, this is the part where you come in, where you kind of look at the slides and make sure that there's enough. Is there enough for molecular diagnostics and as well as IHC if you're going to do it, and just for if you want to make the rest of the smears. So knowing what kind of testing is provided in your institution, you also want to know what the clinicians, the other clinicians would want or expect. So this is where you are triaging. You're looking at the slide, looking at the smears. You might want to rinse it to make it into a block, or you want to use liquid-based cytology, depending on what you do. And you provide the molecular material for the technique. Either you're going to use sections from the block, or you're going to scrape off cells, or you're just going to do a direct with the cells. A lot of times you will be asked to do to count the cells, and this is helpful if you have what they call a graticoux. If you don't, you can kind of figure it out by actually counting, like imagining in your head using a ruler maybe, and counting the number of different cells. And depending on the testing, as we said, you might have certain areas that you would like, you will map, so that those are the areas that will be used for the molecular testing. 1 cell equals to 6 to 7, 1 intact diploid. So anyways, you could look over here. Ah, yes. So the different types of sequencing, different types of testing has pros and cons, and each one has the amount of cells that would be needed. So you can calculate how many, if a DNA test requires 1 nanogram, how many cells would you need to get that 1 nanogram? You see what I mean? Next, let's talk about the clinical applications. So molecular testing has been more and more incorporated and is being used for screening, treatment, diagnosis, prognosis, so on and so forth. Perhaps the one that everybody knows about, the majority, is the HPV, right? So HPV, as we know, HPV is a dsDNA virus, over 150 genotypes. The carcinogenic groups are group 1, 2, 1, and possibly 1, 2A, and possibly 2B. Group 3 is not classified. Those are the ones that cause genital warts and so on. So the main use of it is, you can refer to the other presentation about HPV for a more extensive overview of global and vaccine realities. Let's talk about the screening. So the screening, as you know, has both sides of cytology as well as HPV testing. So let's just talk about the HPV testing right now. HPV testing has a number of different platforms. You have QIAGEN, Hologic, Cobas, Aptima, and it's, generally speaking, it has an average of sensitivity about 20 to 40% lower. Cytology is less sensitive than the HPV testing. It has become more and more mainstream. Now you can actually, send in a sample and have that given back to you through the drugstore. But it continues to be a challenge for the lower income settings. And this is kind of being assessed, and there's more newer platforms like the CARE, which is like, for lower income settings. But there are a number of different ones, different kind of settings that for sure would be needed to be validated before you could use it widespread. So that is the main use of the testing. We're not going to go into cytology because that is a different lecture, but when you put those two together, that's where you have the management. So you have the results of the cytology, you have the results of the testing, and that's how you know how you're going to manage this 21 to 24-year-old lady with ASCUS. You can go to the ASCP to look at the managements. Generally speaking, co-testing is more and more being common, and in some countries, actually, the first line is the molecular testing. Let's talk about lung. How and where is molecular testing being used in lung? So lung cancer has also come a long way with regards to treatments that are based on the molecular testing, and it's totally been incorporated into the National Comprehensive Cancer Network management and screening. So generally nowadays you need, there's tier 1, tier 2, and tier 3. Tier 1, you have to test for EGFR, ALK, ROS1, BRAF. You should test for MET, RES, and KRAS, and then there's a May test for the other ones. Generally speaking, there's different characteristics that you might suspect while looking at a cytology sample. So the adenocarcinomas, for example, EGFR is commonly seen in Asian patients. So if you have an Asian patient, patients that have never smoked maybe, and these ones have a 70% response to tyrosine kinase. This is a really obvious example of what adenocarcinoma would look like on your rows if you're doing DIFQuick, these groups of cells with large NC ratio and occasionally vacuolated cytoplasm. KRAS is very common in the mucinous subtype and the smokers, and these ones have tyrosine kinase resistance. So a mucinous one would have much more of these vacuolated kind of cells, and it has a much more bubbly kind of look to it. This is what it might look like on a cell block of the cells. ALK, this is a lesser number, 3 to 6% non-small cells. It's a rearrangement, not a mutation. It occurs commonly in young males. And this is very common in the signet ring subtype. So this would be more of an example of a signet ring, right? And yeah, let's see this one again. Is this a signet ring too? Yeah, this is a signet ring. I apologize. Yeah, that looks like a signet ring as well. All right, so yeah, signet ring cells, vacuolated cytoplasm, mucinous, can also have signet ring cells, and these ones respond to the MET-ALK inhibitor, and last of all, ROS1, which responds to crizotide. Now, PD-L1 is a more recent thing that has also been used. Used, and you might be asked to assess the PD-L1. And for these ones, you want to know the different type of clone so that you can provide the adequate percentage and what they're being treated for. Okay. So here is a KRAS testing, and then EGFR, and then you try. So this shows how to the pathway of testing, and as well as how these patients will be based on their testing results. All of these, you can look them up on the NCCN guidelines. Thyroid. So thyroid has become quite well known, because it also has a Bethesda system for reporting the different levels. And each one of these categories, to an extent, corresponds to could correspond potentially to a molecular change. Depending on which type of level it is, you would do a molecular testing. So depending on what it is, there's a number of different companies. I do not own stock in any of these. Afirma, Thygenex, Thyromer, Thyroseq, Thyrosec, I guess. Each one has its own requirements, and so you would have to know pretty much which one, what they need. So, for example, Afirma would need fresh cells. Rosetta GX needs fixed cells, and so on. Let's look at some of these. So these ones are suspicious for papillary thyroid carcinoma. You could see the inclusions. You can see, let's see if we can find one with some nice grooves. Yeah, these are the grooves. So this one, you might say this is PTC or suspicious for PTC. IS Orphan Annie, strange cartoon character with no pupils. Suspicious for follicular neoplasm. So these ones are the ones, you can see them forming little follicles. These are the ones that are fairly straightforward, right? Medullary anaplastic. You can kind of tell those as well. Now, and then you have the atypical cells. Atypia of uncertain significance, or a follicular lesion of uncertain significance, right? You're not really sure where to go, and that's where the molecular testing will be helpful. So, malignant, surgical referral, high-risk total thyroidectomy. Indeterminate, let's do a molecular test, and then do a surgical referral, and based on that, a thyroidectomy, or do a molecular test and find that it's low risk and do just clinical follow-ups. So depending on what the result is, that's how it will be done. So classic PTC is RET, follicular carcinoma PAX8, follicular carcinomas RAS. So a lot of times it shows you the reports are either as benign or suspicious. They have a high negative predictive value, so 95% for AUS, 95% for FLUS. Specificity and positive predictive value are 52 and 47. So the test is best at establishing a benign diagnosis, allowing decreased surgeries and number of surgeries. That's for thyroid. For urine. Urine also has something called a Paris system. Paris system for reporting the urinary cytology. Negative, atypical, suspicious, high grade, low grade. And once again, the high grade ones are fairly obvious. So this is a very nice, algorithm that you can use for when diagnosing your urine cytology. What's this? Risk of malignancy. So unsatisfactory, non-diagnostic, negative. The atypical urothelial cells have a fairly large range from 8 to 35 and suspicious 50 to 90. So negative for high grade, sure. Negative for high grade, absolutely. Negative for high grade, why not? Reactive stuff. Yep, these are all degenerating kind of cells. So that one's pretty good for negative for high grade. Here's a nice group of urothelial cells all together. They're looking happy. What about suspicious? Now we're starting to worry a little. Starting to worry. Look how busy that is. And starting to worry. Are we worrying here? Yep, worrying here as well. So then we start worrying. When we start worrying, that's when we, let's see. So AUS, mild to moderate cytologic, not architectural atypia. And you can review the different major and minor criteria. There's also a lecture on the urothelial, cytology of urothelium. You can always go back into that. So where do we use molecular for? Molecular is used for something called an anticipatory positive FISH. These are patients who are under surveillance for recurrent bladder cancer. These can give positive FISH in 26% of otherwise negative. And 50 to 80% of these patients will develop recurrent carcinoma. And like we said, it's FISH. There are some false negatives. There are also some false positives. But generally speaking, sensitivity is 72% alone, specificity 83%. Cytology alone has 42% and the specificity of 96%, which is why they're combined together. FYI, low grade has a deletion P16 at 9p21, high grade aberrations of chromosomes 1, 3, 7, 9, 11, and 17. The most well-known is the Eurovision kit, and this is an FDA-approved molecular test that looks for the FISH detection and scores as positive or negative. So, salivary gland. Salivary gland also has the Milan system. The Milan system describes, this has not become completely mainstream, but supposedly at some point, or presumably it might. So you also have the benign neoplasms, and then you have the areas of the suspicious or malignant, and then you have AUS or SUMP, which are salivary glands of undetermined or uncertain malignant potential. So a lot of the salivary glands share a lot of intratumoral heterogeneity, and so you might find oncocytic cells in many different types, squamous metaplasia, different type, clear cells, hyaline globules, myeloepithelial cells, and so on and so forth. A lot of these tumors do have molecular profiles, so pleomorphic adenoma, adenocystic, secretory, what else? So on and so forth. And each one of these has a different molecular alteration. So it's helpful in the cases where you are unsure. So this is a case that which had a parotid mass. It was a parotid mass, and it was positive for the ETB6 by FISH. And so that was helpful in knowing that this is the secretory carcinoma in situ. You can also obviously do some immunohistochemistry. Let's see what else. So this is another example. So it can be helpful in trying to determine or confirm a case which isn't quite fitting the way you imagine it. Pancreas. Pancreas is slowly becoming mainstream. There's a couple of commercial tests. They look for the KRAS mainly, but this is an example of an algorithm of how it could be incorporated, mainly in cystic lesions. So you have a cyst that's more than 1.5 centimeters, it has a solid component, dilated duct, etc. You do an FNA. So it's either suspicious or it's criterion 2 mucinous test, more than 3 centimeters. Criterion 3, you detect KRAS or GNAS, right? So let's see, if it has criteria 1 or 2, then you're going down this way, right? So, and then you have different plans for each one. And this is an example of how it is being incorporated into different things. And here we can have a quick overview of what we can look at. This is solid pseudopapillary, neoplasm, right? And then let's see what other pictures we have here. Benign ductal cells, mucin. Okay. And then over here, a mucinocystic neoplasm. That's what it looked like on the, and then you have atypical cells, but no mucin. This is one that would be helpful, right? And IPMN for that one. And what's this one? A pseudocyst. And then this was cystic too. So keep in mind the neuroendocrines. Neuroendocrines could be cystic as well. So these are the ones that, so it could be helpful. IPMN, this is another table which shows the IPMN, MCN, SCA, non-neoplastic cysts, and their different key molecular translocations. And so the main use in pancreatic is pancreatic cysts. And this is kind of helpful to understand because imaging alone, cytology alone, biochemical alone, biochemical and molecular together, and then molecular. So more and more, it is becoming, once again, like I said, mainstream. Now, lastly, you have a bunch of other things. Let's talk a moment for uveal melanoma. The main company doing this is Castle. Once again, I do not own any kind of stock in these. And based on the results, they give different classes as to whether or not there's a risk of clinical metastases of uveal melanoma. FFPE, cytology. These are examples of uveal melanoma positive for, I guess this is S100. Let's see. And here we are. So that's an example of where that's being used. Diagnosis, again, obviously in cases of sarcomas, a lot of the time you can use the cytology for that. This is an example of a case that we actually published because it was an interesting case of biphasic that once it metastasized to the rib became epithelial component. And there is something called the complexity index called CINSARC, which is a French company. And this divides patients of sarcoma into 2 different groups. With regards to cancer, it hasn't really been used, but there is Foundation 1, for diagnostics as much as it's used for, let's see, so there's different types, Oncotype, Mammaprint, Mammastrat. Once again, it's used mainly for prognosis, is what I'm trying to say. So you get a score based on what kind of cancer this is. Here's some cytology of breast cancer. Lymphoma. Lymphoma has, there's always the 2 groups who insist that they can, diagnose lymphoma based on cytology, and other ones who insist that it would be difficult. But so this area is still not resolved. And that's the end of this lecture, and thank you very much for